Foundations of Maternal, Newborn, and Women's Health Nursing by Murray, McKinney, Holub, and Jones. Chapter 12, Processes of Birth. Understanding the physiologic and psychological components of the birth process helps the nurse provide safe, effective care for the childbearing family. Awareness of expected changes allows the nurse to support the laboring woman when these occur and provides a basis for identifying abnormal occurrences. This chapter focuses on the physiology of birth. Physiologic effects of the labor process. The birth process affects the physiologic systems of both the mother and fetus. Maternal response. The most obvious changes of pregnancy and birth occur in the woman's reproductive system, but significant changes also occur during labor in her cardiovascular, respiratory, gastrointestinal, urinary, and hematopoietic systems. Reproductive system. Characteristics of contractions. Normal labor contractions are coordinated, involuntary, and intermittent. Coordinated. The uterus can contract and relax in a coordinated way like the heart and other smooth muscles. Contractions during pregnancy are of low intensity and uncoordinated. As the woman approaches full term, contractions become organized and gradually assume a regular pattern of increasing frequency. Period from the beginning of one uterine contraction to the beginning of the next. Duration. Period from the beginning of a uterine contraction to the end of the same contraction. And intensity. Strength of a contraction during labor. Coordinated labor contractions begin in the uterine fundus and spread downward toward the cervix to propel the fetus through the pelvis. Involuntary. Uterine contractions are involuntary and are not under conscious control. The mother cannot cause labor to start and stop by conscious effort. However, walking and other activities may stimulate existing labor contractions. Anxiety and excessive stress can diminish contractions because of elevated adrenaline levels that may cause uterine relaxation. Relaxation can facilitate the natural processes. Intermittent. Labor contractions are intermittent rather than sustained, allowing relaxation of the uterine muscle and resumption of blood flow to and from the placenta. Contraction cycle. Each contraction consists of 3 phases, figure 12.1. The increment, period of increasing strength, occurs as the contraction begins in the fundus and spreads throughout the uterus. The peak, or acme, is the period during which the contraction is most intense. The decrement is the period of decreasing intensity as the uterus relaxes. The contraction cycle and pattern of contractions are also described in terms of frequency, duration, and intensity. Frequency may be expressed in minutes and fractions of minutes, e.g., contractions are 3.5 to 4 minutes apart. The 2008 National Institute of Child Health and Human Development update recommends the frequency be assessed as the number of contractions in 10 minutes, averaged over 30 minutes, 3 contractions in 10 minutes. Duration is usually expressed in seconds, e.g., contractions lasted 55 to 65 seconds. The terms mild, moderate, and strong describe contraction intensity as palpated by the nurse. Different descriptions of intensity apply when an internal pressure catheter is used to record contractions. See Chapter 14. The interval is the period between the end of one contraction and the beginning of the next. The uterus should palpate soft during this time. Most fetal exchange of oxygen, nutrients, and waste products occurs in the placenta at this time. Uterine muscle. Uterine activity during labor is characterized by opposing features. The upper two-thirds of the uterus contracts actively to push the fetus down. The lower third of the uterus remains less active, promoting downward passage of the fetus. The cervix is passive. The net effect of labor contractions is enhanced because the downward push from the upper uterus is accompanied by reduced resistance to fetal descent in the lower uterus. Myometrial, pertaining to the uterine muscle, cells in the upper uterus remain shorter at the end of each contraction rather than returning to their original length. Myometrial cells in the lower uterus become longer with each contraction. These two characteristics enable the upper uterus to maintain tension between contractions to preserve the cervical changes and downward fetal progress made with each contraction. The opposing characteristics of myometrial contraction in the upper and lower uterine segments cause changes in the thickness of the uterine wall during labor. The upper uterus becomes thicker, and the lower uterus becomes thinner and is pulled upward during labor. The physiologic retraction ring marks the division between the upper and lower segments of the uterus, figure 12.2. The upper and lower uterine segments work opposite of each other, causing the uterine cavity to change shape, becoming more elongated and narrow as labor progresses. This change in uterine shape straightens the fetal body and efficiently directs it downward in the pelvis. Cervical changes. Effacement, thinning and shortening, and dilation, opening, are the major cervical changes during labor. Effacement and dilation occur concurrently during labor, but at different rates. The nullipara, a woman who has not completed a pregnancy of at least 20 weeks of gestation, completes most cervical effacement early in the process of cervical dilation. In contrast, the cervix of a parous woman, a para is a woman who has given birth after a pregnancy of at least 20 weeks gestation. It also designates the number of pregnancies that end after at least 20 weeks of gestation, is usually thicker than that of a nullipara at any point during labor. Effacement. Before labor, the cervix is a cylindrical structure about 3.5 centimeters long at the lower end of the uterus. Toward the end of pregnancy, the cervix becomes softer and more pliable to prepare for labor. Labor contractions push the fetus downward against the cervix while pulling the cervix upward. If the membranes are intact, hydrostatic fluid pressure of the amniotic sac adds to the force of the presenting part, the part of the fetal body that enters the pelvis first, on the cervix. The cervix becomes shorter and thinner as it is drawn over the fetus and amniotic sac. Figure 12.3. The cervix merges with the thinning lower uterine segment rather than remaining a distinct structure. Effacement is estimated as a percentage of the original cervical length. A fully thinned cervix is 100% effaced. Dilation. As the cervix is pulled upward and the fetus is pushed downward, the cervix dilates. Dilation is expressed in centimeters. Full dilation is approximately 10 centimeters, sufficient to allow passage of the average size full-term fetus. At 10 centimeters, the cervix cannot be felt by an examiner. The action during effacement and dilation can be likened to pushing a ball out through the cuff of a sock. Cardiovascular system. During each uterine contraction, the muscle fibers of the uterus constrict around the maternal spiral arteries that supply the placenta. This temporarily shunts 300 to 500 milliliters of blood back into maternal systemic circulation, thereby causing a relative increase in the woman's blood volume. This temporary change increases her blood pressure slightly and slows her pulse rate. Therefore, the woman's vital signs are best assessed during the interval between contractions. Supine hypotension may occur during labor if the woman lies on her back as a result of aortocaval compression. The woman should be encouraged to rest in lateral positions to promote blood return to her heart and thus enhance blood flow to the placenta and promote fetal oxygenation. Respiratory system. The depth and rate of respirations increase during labor, especially if the woman is anxious or in pain. A woman who breathes rapidly and deeply may experience symptoms of hyperventilation. Respiratory alkalosis occurs as she exhales too much carbon dioxide. She may feel tingling of her hands and feet, numbness, and dizziness. The nurse should help her slow her breathing through relaxation techniques and breathe into a paper bag or her cupped hands to restore normal blood levels of carbon dioxide and relieve these symptoms. Gastrointestinal system. Gastric motility is reduced during labor, which can result in nausea and vomiting. Controversy exists on whether laboring women should be allowed to eat or drink during labor. Concerns surround the risk for vomiting and aspiration of undigested foods in the event general anesthesia is required. In a Cochrane review, a lack of evidence was found to restrict low-risk laboring women from food and oral fluids during labor. The maternal need for calories to perform the work of labor is underappreciated. Increased glucose utilization and oxygen consumption occur during labor, resulting in the need for additional nutrition. The American Society of Anesthesiologists Practice Guidelines for Obstetrical Anesthesia position statement on aspiration prevention states that oral intake of clear liquids is appropriate in low-risk laboring women. However, solid foods should be avoided. Ice chips, juices, and popsicles in moderate amounts are common options available to women during labor. Urinary system. The most common change in the urinary system during labor is a reduced sensation of a full bladder. Because of intense contractions and the effects of regional anesthesia, the woman may be unaware that her bladder is full, yet it can contribute to discomfort. A full bladder can inhibit fetal descent because it occupies space in the pelvis. Bladder status should be evaluated throughout labor for distension. Hematopoietic system. Most authorities recognize 500 milliliters as the maximum normal blood loss during vaginal birth. Women usually tolerate this loss well because the blood volume increases during pregnancy by 30% to 60%. A woman who is anemic at the beginning of labor has less reserve for normal blood loss and a poor tolerance for excess bleeding. A hemoglobin level of 11 grams per deciliter and a hematocrit of 33% or higher before birth give most women an adequate margin of safety for blood loss associated with normal birth. The leukocyte count may be 20,000 to 30,000 per cubic millimeter during active labor with no other evidence of infection. Levels of several clotting factors, especially fibrinogen, are elevated during pregnancy and continue to be higher during labor and after delivery. This increase provides protection from hemorrhage, but also increases the mother's risk for a venous thrombosis during pregnancy and after birth. Fetal response. Placental circulation. The exchange of oxygen, nutrients, and waste products between the mother and fetus occurs in the intervillous spaces of the placenta without mixing of maternal and fetal blood. During strong labor contractions, the maternal blood supply to the placenta decreases as the spiral arteries supplying the intervillous spaces are compressed by the uterine muscle. Therefore, most placental exchange occurs during the interval between contractions. The placental circulation usually has enough reserve compared with fetal basal needs to tolerate the periodic interruption of blood flow. Fetal protective mechanisms include the following: fetal hemoglobin, HGBF, which more readily takes on oxygen and releases carbon dioxide when compared to maternal hemoglobin, high hemoglobin and hematocrit levels that can carry more oxygen than adult hemoglobin, a high cardiac output. The fetus may not tolerate labor contractions well in conditions associated with reduced placental function, such as maternal diabetes and hypertension, and conditions associated with reduced fetal oxygen carrying capacity, such as fetal anemia. Cardiovascular system. The fetal cardiovascular system reacts quickly to events during labor. Alterations in the rate and rhythm of the fetal heart may result from normal labor effects or suggest fetal intolerance to the stress of labor. The fetal heart rate, FHR, is rapid and ranges from 110 to 160 beats per minute, BPM, at term. The preterm fetus often has a rate in the higher end of this range. Pulmonary system. The fetal lungs produce fluid to allow normal development of the airways. The fetus also has breathing motions in utero, breathing in amniotic fluid. Lung fluid must be cleared to allow normal air breathing after birth. As term nears, production of fetal lung fluid decreases to approximately 65% of its maximum production, and its absorption into the interstitium of the lungs increases. Labor speeds the absorption of lung fluid. Approximately 35% of the maximum amount remains in the airways at birth. Some fluid is expelled from the upper airways as the fetal head and thorax are compressed during passage through the birth canal. Most remaining lung fluid is absorbed into the interstitial spaces of the newborn's lungs and then into the circulatory system. A small amount is cleared by the lymphatic circulation. Catecholamines, primarily epinephrine and norepinephrine, produced by the fetal adrenal glands in response to the stress of labor, appear to contribute to the infant's adaptation to extrauterine life. They stimulate cardiac contraction and breathing, quicken the clearance of remaining lung fluid, and aid in temperature regulation. Infants born by cesarean birth, not preceded by labor, are more likely to have transient breathing difficulty. 4 major factors interact during normal childbirth. These factors are often called the 4 Ps: powers, passage, passenger, and psyche. Powers. Uterine contractions. During the first stage of labor, onset to full cervical dilation, uterine contractions are the primary force that moves the fetus through the maternal pelvis. Maternal pushing efforts. During the second stage of labor, full cervical dilation to birth of the baby, uterine contractions continue to propel the fetus through the pelvis. In addition, the woman feels an urge to push and bears down as the fetus distends her vagina and puts pressure on her rectum. Her voluntary pushing efforts add to the force of uterine contractions in second stage labor. Passage. The birth passage consists of the maternal pelvis and soft tissues. The bony pelvis is usually more important to the outcome of labor than the soft tissue because the bones and joints do not readily yield to the forces of labor. However, softening of the cartilage linking the pelvic bones occurs near term because of increased levels of the hormone relaxin. The linea terminalis, pelvic brim, divides the bony pelvis into the false pelvis top and true pelvis bottom. See Chapter 3. The true pelvis is most important in childbirth. The true pelvis has three subdivisions. 1, the inlet or upper pelvic opening. 2, the mid-pelvis or pelvic cavity. And 3, the outlet or lower pelvic opening. During birth, the true pelvis functions such as a curved cylinder with different dimensions at different levels. Figure 12.4. Passenger. The passenger is the fetus, membranes, and placenta. Several fetal anatomic and positional variables influence the course of labor. Fetal head. The fetus enters the birth canal in the cephalic presentation, the fetal part that enters the pelvic inlet first, 96% of the time. The fetal shoulders are also important because of their width, but they usually can be moved to adapt to the diameter of the pelvis. Bones, sutures, and fontanelles. The bones of the fetal head involved in the birth process are the 2 frontal bones on the forehead, 2 parietal bones at the crown of the head, and 1 occipital bone at the back of the head. Figure 12.5. The 5 major bones are not fused, but are connected by sutures, which are narrow areas of flexible tissue that connect fetal skull bones, permitting slight movement during labor. The fontanelles are wider spaces at the intersections of the sutures connecting fetal or infant skull bones. The anterior fontanelle has a diamond shape formed by the intersection of 4 sutures. The 2 coronal, frontal, and sagittal sutures, which connect the 2 frontal and 2 parietal bones. The posterior fontanelle has a triangular shape formed by the intersection of 3 sutures, 1 sagittal and 2 lambdoid sutures, which connect the 2 parietal bones and occipital bone. The posterior fontanelle is very small and often looks or feels more like a slight indentation in the skull. The sutures and fontanelles allow the bones to move slightly, changing the shape of the fetal head so it can adapt to the size and shape of the pelvis by molding, shaping of the fetal head during movement through the birth canal. The sutures and different shapes of the fontanelles provide important landmarks to determine fetal position, relation of a fixed reference point on the fetus to the quadrants of the maternal pelvis, and head flexion during vaginal examination. Fetal head diameters. Most fetuses enter the pelvis in the cephalic presentation, but several variations are possible. The major transverse diameter of the fetal head is the biparietal diameter, measured between the 2 parietal bones. The biparietal diameter averages 9.5 centimeters in a term fetus. The antero-posterior diameter of the head varies with the degree of flexion. In the most favorable situation, the head becomes fully flexed during labor, and the antero-posterior diameter is suboccipitobregmatic, averaging 9.5 centimeters. See Figure 12.5b. Fetal lie. The orientation of the long axis of the fetus to the long axis of the woman is called a fetal lie. Figure 12.6. In more than 99% of pregnancies, the lie is longitudinal and parallel to the long axis of the woman. In the longitudinal lie, either the head or the buttocks of the fetus enter the pelvis first. A transverse lie exists when the long axis of the fetus is at a right angle to the woman's long axis. This occurs in less than 1% of pregnancies. An oblique lie is at some angle between the longitudinal lie and the transverse lie. Attitude. The relation of fetal body parts to one another is the attitude of the fetus, figure 12.7. The normal fetal attitude is one of flexion, with the head flexed toward the chest and the arms and legs flexed over the thorax. The back is curved in a convex C shape. Flexion remains a characteristic feature of the term newborn. Presentation. The fetal part that enters the pelvis is termed the presenting part. Presentation falls into three categories: 1 cephalic, 2 breech, and 3 shoulder. The cephalic presentation with the fetal head flexed is the most common. Other presentations are associated with prolonged labor and are more likely to require cesarean birth. Cephalic presentation. The cephalic presentation is more favorable than others for the following reasons. The fetal head is the largest single fetal part, although the breech, buttocks, with the legs and feet flexed on the abdomen, is collectively larger than the head. After the head is born, smaller parts follow easily as the extremities unfold. During labor, the fetal head can gradually change shape, molding to adapt to the size and shape of the maternal pelvis. The fetal head is smooth, round, and hard, making it a more effective part to dilate the cervix, which is also round. Cephalic presentation has the following 4 variations. Figure 12.8. Vertex. This is the most common type of cephalic presentation, which the fetal head is fully flexed. It is called a vertex or occiput presentation, and the most favorable for normal progress of labor because the smallest suboccipitobregmatic diameter is presenting. Military. The head is in a neutral position, neither flexed nor extended. The longer occipitofrontal diameter is presenting. Brow. The fetal head is partly extended. The brow presentation is unstable, usually converting to a vertex presentation if the head flexes or to a face presentation if it extends. The longest supraoccipitomental diameter is presenting. Face. The head is extended and the fetal occiput is near the fetal spine. The submentobregmatic diameter is presenting. Breech presentation. A breech presentation occurs when the fetal buttocks or legs enter the pelvis first, which happens in approximately 3 to 4% of births. Breech presentation is more common in preterm births. Hydrocephaly, enlargement of the head with fluid, multiple gestations, abnormalities of the maternal uterus and pelvis, and with placenta previa, placenta in the lower uterus. Breech presentations are associated with the following disadvantages. The buttocks are not smooth and firm like the head and are less effective at dilating the cervix. The fetal head is the last part to be born. By the time the fetal head is deep in the pelvis, the umbilical cord is outside the mother's body and is subject to compression between the fetal head and the maternal pelvis. Because the umbilical cord can be compressed after the fetal chest is born, the head should be delivered quickly to allow the infant to breathe. This does not permit gradual molding of the fetal head as it passes through the pelvis. The breech presentation has the following 3 variations, depending on the relationship of the legs to the body. Figure 12.9. Frank breech. This is the most common variation, occurring when the fetal legs are extended across the abdomen toward the shoulders. Complete breech. This is a reversal of the usual cephalic presentation. The head, knees, and hips are flexed, but the buttocks are presenting. Footling breech. This occurs when one or both feet are presenting. Shoulder presentation. The shoulder presentation is a transverse lie and accounts for only 0.3% of births. It occurs more often with preterm birth, high parity, prematurely ruptured membranes, hydramnios, and placenta previa. A cesarean birth is necessary when the fetus is viable, one of a gestational age that might survive. Position. Fetal position describes the location of a fixed reference point on the presenting part in relation to the four quadrants of the maternal pelvis, figure 12.10. The four quadrants are the right and left anterior and the right and left posterior. The fetal position is not fixed, but changes during labor as the fetus moves downward and adapts to the pelvic contours. Abbreviations indicate the relationship between the fetal presenting part and the maternal pelvis, right R or left L. The first letter of the abbreviation describes whether the fetal reference point is to the right or left of the mother's pelvis. If the fetal reference point is neither to the right nor to the left of the pelvis, the letter is omitted. Occiput O, mentum M, or sacrum S. The second letter of the abbreviation refers to the fixed fetal reference point, which varies with the presentation. The occiput is used in a vertex presentation. The chin, or mentum, is the reference point in a face presentation. The sacrum is used for breech presentations. Letters may also designate the less common brow, F for fronto, and shoulder, SC for scapula, presentations. Anterior A, posterior P, or transverse T. A, P, and T describe whether the fetal reference point is in the anterior or posterior quadrant of the mother's pelvis. If the fetal reference point is in neither an anterior nor a posterior quadrant, it is described as transverse. If the fetal occiput is in the left anterior quadrant of the mother's pelvis, the position is described as left occiput anterior, LOA. If the occiput is in the mother's anterior pelvis, neither to the right nor to the left, is described as occiput anterior, OA. If the fetal sacrum is in the mother's right posterior pelvis, the abbreviation is R right, S sacrum, P posterior, figure 12.11. Psyche. A woman's psychological response to labor and birth are influenced by anxiety, culture, expectations, life experiences, and support. Anxiety. Marked anxiety and fear may decrease a woman's ability to cope with pain in labor. Maternal catecholamines secreted in response to anxiety and fear can inhibit uterine contractility and placental blood flow. In contrast, relaxation augments the natural process of labor. Prenatal education or childbirth classes can increase a woman's knowledge, enhancing her ability to work with her body's efforts rather than resist the natural forces. Much of the nurse's care during labor involves reducing anxiety and fear and assisting with coping strategies. Information, a positive sense of control, and mastery over the birth increase the woman's sense of satisfaction with her birth experience. Culture and expectations. A woman's culture affects her values and expectations for, and responses to, birth and the practices surrounding it. A nurse's familiarity with a group's cultural values and practices provides a framework to care for the woman and her family as individuals. The nurse should assess the personal expectations and values of each woman and her support person related to birth within the general framework. Questions for the intrapartum period might include the following. Are they recent immigrants or have their relatives and friends lived in the area for generations? What is the primary language used? Do the woman and her support person speak the same language? Are they comfortable communicating in the nurse's language if that is not their usual language? How does a woman with hearing impairment communicate with people who can hear? If an interpreter is needed, what people would the woman or her family consider unacceptable interpreters, e.g., men or members of certain religious groups? Who is the woman's primary support person for labor? What is that person's role? Will that person actively support the laboring woman, e.g., by coaching her breathing, or will he or she take a less active role? Who will be present at the birth? Who is the decision maker, or who should be consulted about important decisions? Will another relative, such as a grandmother, assume primary care for the infant? Is a professional caregiver, such as a nurse or physician, of the same gender and cultural group essential? What are the woman's feelings about touch? Is she comfortable telling the nurse when she does not welcome touch? How is pain perceived? What are acceptable pain levels and appropriate pain reduction strategies? Are specific symbols, practices, and ceremonies used during the birth period? Who will conduct any ceremonies? Birth as an experience. Childbirth is a physical and emotional experience. It is an irrevocable event that forever changes a woman and a family. Families describe the births of their children as they describe other pivotal events in life, such as marriages, anniversaries, religious events, and even deaths. A woman who has realistic expectations about birth is more likely to have a positive experience. Nursing measures that increase the woman's sense of control and mastery during birth help her perceive the birth as a positive event. The woman's past experiences with childbirth, pain, and personal success and failure will influence her expectations for this birth. Support. The positive effects of continuous labor support are well documented. Support includes physical comfort measures, providing information, advocacy, praise and reassurance, presence, and the maintenance of a calm and comfortable environment. Interrelationships of components. The 4 P's have been described separately but are actually an interrelated whole. For instance, a woman with a small pelvis, passage, and a large fetus, passenger, may be able to have a normal labor and birth if the fetus is ideally positioned and the uterine contractions and maternal bearing down efforts, powers, are vigorous. The nurse's supportive attitude strengthens positive psychological elements, psyche, and enhances the process of birth. The nurse can act as an advocate for the laboring woman and her support person to increase their sense of control and mastery of labor, which often reduces anxiety and fear and helps them achieve their desired birth experience. Normal labor. Theories of onset. Despite continuing research, the exact mechanisms that initiate labor remain unknown. Labor normally starts when the fetus is mature enough to adjust easily to extrauterine life, but before it grows so large that vaginal birth is impossible. This stage, term gestation, occurs between 37 and 42 weeks after the first day of the woman's last menstrual period. One or more sonograms early in pregnancy may have influenced the due date, especially for the woman who often has irregular periods. Natural labor begins when forces favoring continuation of pregnancy are offset by forces favoring its end. Research is ongoing in this area. Factors that appear to have a role in starting labor include the following. Changes in the ratio of maternal estrogen to progesterone so that estrogen levels are higher than progesterone levels. Progesterone promotes smooth muscle relaxation of the uterus during most of pregnancy. Relatively higher estrogen levels as progesterone levels fall near the onset of labor enhance uterine sensitivity to substances that stimulate uterine contractions, prostaglandins from the fetal membranes, and oxytocin from the maternal posterior pituitary gland. Estrogens increase the number of gap junctions, connections that allow the individual uterine muscle cells to contract as a coordinated unit. Prostaglandins produced by the decidua and membranes may have a role in preparing the uterus for oxytocin stimulation at term. Prostaglandins are secreted from the lower area of the fetal membranes, forebag, during labor and may reflect inflammation caused by contact with microorganisms from the woman's vagina. Increased secretion of natural oxytocin appears to maintain labor once it has begun. Oxytocin alone does not appear to start labor, but may play a part in labor's initiation in conjunction with other substances. Evidence of fetal oxytocin secretion also exists. Oxytocin receptors in the uterus increase markedly as labor begins, and the increase continues during labor and peaks at delivery. Oxytocin has little effect on the uterine muscle if the receptors have not developed. A fetal role in the initiation of labor appears likely. The fetal membranes release prostaglandin in high concentrations during labor. In addition to fetal oxytocin secretion, large quantities of cortisol are secreted by the fetal adrenal glands, possibly acting as a uterine stimulant. Stretching, pressure, and irritation of the uterus and cervix increase as the fetus reaches term size. During early pregnancy, the uterus has not reacted to stretching by contracting as smooth muscle normally does. A feedback loop is likely responsible for labor contractions at term. The fetal head stretches the cervix, causing the fundus of the uterus to contract, pushing the fetal head against the cervix and causing more fundal contractions. Cervical stretching also causes secretion of oxytocin. Premonitory signs. Braxton Hicks contractions. As term gestation approaches, Braxton Hicks contractions, irregular mild uterine contractions that occur throughout pregnancy and become stronger in the last trimester, become more noticeable and even painful. Parous women often describe more uterine activity preceding labor than do nulliparous women. Increased perception of Braxton Hicks contractions often makes sleep difficult at the end of pregnancy. The contractions may become regular at times, only to decrease spontaneously. These contractions are often uncomfortable and sometimes regular, which can cause women to be confused about whether labor has begun. Lightening. As the fetus descends toward the pelvic inlet, dropping, the woman notices that she breathes more easily because upward pressure on her diaphragm is reduced. However, increased pressure on her bladder causes her to urinate more frequently. Pressure on the fetal head in the pelvis also may cause leg cramps and edema. Lightening, descent of the fetus toward the pelvic inlet before labor, is most noticeable in nulliparas and occurs about 2 to 3 weeks before the natural onset of labor. Increased vaginal mucus secretions. An increase in clear and non-irritating vaginal secretions occurs as fetal pressure causes congestion of the vaginal mucosa. Cervical ripening and bloody show. As full term nears, the cervix softens because of the effects of the hormone relaxin. These changes, ripening, allow the cervix to yield more easily to the forces of labor contractions. As the fetal head descends with lightening, it puts pressure on the cervix, starting the process of effacement and dilation. Effacement and dilation cause expulsion of the mucus plug that sealed the cervix during pregnancy, rupturing small cervical capillaries in the process. Bloody show, mixture of cervical mucus and pink or brown blood from ruptured capillaries in the cervix, often precedes labor and increases with cervical dilation, may begin several days to a few weeks before the onset of labor, especially in the nulliparous woman, or it may not begin until labor starts. A recent vaginal examination or sexual intercourse also may result in small amounts of bloody show because it disrupts these small vessels. Bloody show increases during labor as the cervix completes dilation and effacement. Women who have previously had a vaginal birth often have less bloody show than nulliparous. Energy spurt. Some women have a sudden increase in energy, which is called nesting. They should be cautioned to conserve their energy so that they are not exhausted when labor begins. Weight loss. A small weight loss of 2.2 to 6.6 kilograms, 1 to 3 pounds, may occur because the altered estrogen to progesterone ratio causes excretion of some of the extra fluid that accumulates during pregnancy. Okay, so I read that as printed, but it's a typo. It should be reversed. That's a weight loss of 2.2 pounds to 6.6 pounds, which is 1 to 3 kilograms. True labor and false labor. False labor, also called prodromal labor or pre-labor, is common because the exact time of labor's onset is rarely known and usually is gradual. False labor often causes women to go to the birth center, thinking that labor has started, only to be disappointed when it has not. Women may be observed in the labor unit for enough time to have 2 cervical examinations to evaluate cervical change. The term false labor is discouraging to women because they do not realize that these false contractions are preparation for true labor. Several characteristics distinguish true labor from false labor: contractions, discomfort, and cervical change. The best distinction between true and false labor is that contractions of true labor cause progressive changes in the cervix. A more rapid increase in effacement and dilation occurs with true labor contractions. Some women experience membrane rupture as the first sign of labor onset. If this occurs, the woman should go to the birth center for evaluation. Infection and compression of the fetal umbilical cord are possible complications. Labor mechanisms. The mechanisms, cardinal movements, of labor occur as the fetus is moved through the pelvis during birth. The fetus undergoes several position changes to adapt to the size and shape of the mother's pelvis at different levels. Figure 12.12. Although the mechanisms of labor are described separately in Figure 12.12, some occur concurrently. In a vertex presentation, the mechanisms include the following: descent of the fetal presenting part through the true pelvis, engagement of the fetal presenting part as its widest diameter reaches the level of ischial spines of the mother's pelvis, 0 station, flexion of the fetal head allowing the smallest head diameters to align with the smaller diameters of the mid-pelvis as the fetus descends, internal rotation to allow the largest fetal head diameters to align with the largest maternal pelvic diameters, extension of the fetal head as the neck pivots on the inner margin of the symphysis pubis, allowing the head to align with the curves of the pelvic outlet, external rotation of the fetal head, aligning the head with the shoulders during expulsion, expulsion of the fetal shoulders and fetal body. The mechanisms of labor are different in presentations other than the vertex, but the reason is the same: to effectively use the available space in the maternal pelvis. Stages and phases of labor. Labor is divided into 4 stages. Each stage has unique qualities, Table 12.1. This chapter describes typical physiologic characteristics and maternal behaviors in the average woman. Women vary in their labor patterns and responses to this process. Regional anesthesia may alter some of the maternal behaviors. First stage. Cervical effacement and dilation occur in the first stage, or the stage of dilation. It begins with the onset of true labor contractions and ends with complete dilation, 10 centimeters, and effacement, 100% of the cervix. The first stage of labor is the longest for both nulliparous and parous women. 3 phases within the first stage are latent, active, and transition. Each phase is characterized by changing maternal behaviors. These behaviors vary with the woman's preparation, use of coping skills, and use of medication. When the active phase begins, the cervix of the nullipara usually dilates at a slower rate than that of the multipara, a woman who has given birth after 2 or more pregnancies of at least 20 weeks gestation. Also informally used to describe a pregnant woman before the birth of her second child. Historically, labor progress often has been plotted on a labor progress graph called a Friedman curve, figure 12.13. Current research suggests that normal labor progresses more slowly than previously believed. Revisions to the labor curve may be made as more data become available. Latent phase. Historically, the latent phase has been defined as 0 to 3 centimeters dilated. However, recent research has suggested that the latent phase be considered to last until 5 to 6 centimeters dilated. Its length varies among women, but may be longer for the nullipara than for the multipara. Latent labor may be quite long, and much of it may pass unnoticed by the pregnant woman as latent labor gradually merges into active labor. Cervical effacement and fetal positional change occur during the latent phase, preparing for the more rapid changes of active labor. Contractions gradually increase in frequency, duration, and intensity. The interval between contractions shortens until contractions are about 5 minutes apart as the woman progresses to the active phase. Duration increases to 30 to 40 seconds by the end of the latent phase. Initially, the contractions are mild. The contracting uterus can be easily indented with the fingertips and progress to moderate intensity, during which the uterine muscle is indented with more difficulty. The contractions gradually build to their peak intensity and remain at the peak briefly before diminishing. During latent labor, the woman may notice discomfort in her back with each contraction. As labor progresses, back discomfort encircles the lower abdomen with each contraction. Many women describe the discomfort as like menstrual cramps, especially during early labor. The woman is usually sociable, excited, and cooperative. She is anxious as she realizes that these contractions are not Braxton Hicks contractions, but the real thing. She is usually relieved that she is close to the birth of her baby. Active phase. When the rate of cervical change accelerates, the woman has progressed to active phase. The fetus descends in the pelvis, and internal rotation begins. Active and transition phases are linked as one phase enters the next, and references may not distinguish the two. For more than 50 years, our understanding of the progress of normal labor has been based on the classic research of Dr. Emanuel Friedman in the 1950s. The Friedman labor curve has been used to assess labor progress in the clinical setting. Per Friedman's work, the active phase of first stage labor begins at 4 centimeters dilation. After this point, a multiparous woman should progress at the rate of 1.5 centimeters per hour, and a nulliparous woman should progress at a rate of 1.2 centimeters per hour. More recent research indicates that for various reasons, modern women progress through labor at a slower rate. Per these findings, the active phase of first stage labor begins at 5 to 6 centimeters dilation. The first stage of labor then lasts an average of 6 to 13.3 hours in the nullipara and 5.7 to 7.5 hours in the multipara. These findings are supported by the American College of Obstetricians and Gynecologists. Contractions are about 2 to 5 minutes apart, with a duration of approximately 40 to 60 seconds and an intensity that ranges from moderate to strong. Active labor contractions resist indenting, reach their peak intensity quickly, and stay at the peak longer than during the latent phase. As contractions intensify, discomfort also increases if the woman has not had analgesia, such as an epidural block. The site of discomfort during the active phase is like that during the latent phase. The woman's behavior changes. She becomes more anxious and may feel helpless as the contractions intensify. The sociability that characterized early labor is gone and is replaced by a serious inward focus. She is unlikely to initiate interactions unless she has specific requests. Her behaviors are typical of a person concentrating intently on a demanding task. Women who choose to take pain medication and regional analgesia usually do so during this phase. The nurse helps the woman maintain her concentration, supports her coping techniques, and helps her find alternatives for methods that do not work for her. Transition phase. The cervix dilates from 8 to 10 centimeters in this phase of the first stage, and the fetus descends further into the pelvis. Bloody show often increases with the completion of cervical dilation. Transition is a short but intense phase within the first stage. Contractions are very strong. They may be as frequent as 1.5 to 2 minutes apart, and their duration is 60 to 90 seconds. Strong contractions combined with fetal descent may cause the woman to have an urge to push and bear down during contractions. Leg tremors, nausea, and vomiting are common. The woman who does not choose epidural analgesia often finds the transition phase to be most difficult part of her labor. She may be irritable and lose control. Her partner may be confused because actions that were helpful just a short time ago now bother her. The nurse can encourage the woman and her support person that the end of labor is near and help them use coping techniques most effectively. If premature bearing down is a problem, the nurse can help the woman blow outward with each breath until the urge passes. Second stage. The second stage, expulsion, begins with complete 10 centimeter dilation and full 100% effacement of the cervix and ends with the birth of the baby. Duration of second stage labor also varies with whether the woman has an epidural. Duration of the second stage for the nullipara with no epidural averages 2.8 hours, whereas the average duration is 3.6 hours with an epidural. Duration of the second stage for the multipara with no epidural ranges from 1.1 to 1.3 hours, and the average duration is 1.6 to 2 hours with an epidural. Contractions may diminish slightly or even pause briefly as the second stage begins. They are still strong and about 2 to 3 minutes apart, with a duration of 40 to 60 seconds. As the fetus descends, pressure of the presenting part on the rectum and the pelvic floor causes an involuntary pushing response in the mother. She may say that she needs to have a bowel movement, or say the baby's coming, or I have to push. Her voluntary pushing efforts augment involuntary uterine contractions. As the fetus descends low in the pelvis and the vulva distends with the crowning of the fetal head, she may feel a sensation of stretching or splitting even if no trauma occurs. The maternal urge to push does not always occur the moment the woman is fully dilated. Allowing the woman to labor down is beneficial in most cases. See Chapter 15. The woman often regains a feeling of control during the second stage of labor. Contractions are strong, but she may feel more in control and know that she is doing something to complete the process by pushing with the contractions. The word labor aptly describes the second stage. The woman exerts intense physical effort to push her baby out. Between contractions, she may be oblivious to her surroundings and appear to be asleep. She feels tremendous relief and excitement as the second stage ends with the birth of the baby. Third stage. The third, placental stage, begins with the birth of the baby and ends with the expulsion of the placenta, figure 12.14. This stage is the shortest, with an average length of 6 minutes. No difference in duration exists between nulliparous and parous women. When the infant is born, the uterine cavity becomes much smaller. The reduced size decreases the size of the placenta site, causing it to separate from the uterine wall. The following 4 signs suggest placenta separation. The uterus has a spherical shape. The uterus rises upward in the abdomen as the placenta descends into the vagina and pushes the fundus upward. The cord descends further from the vagina. A gush of blood appears as blood trapped behind the placenta is released. The uterus must contract firmly and remain contracted after the placenta is expelled to compress open vessels at the implantation site. Inadequate uterine contraction after birth may result in hemorrhage. Pain during the third stage of labor results from uterine contractions and brief stretching of the cervix as the placenta passes through it. Fourth stage. The fourth stage of labor is the stage of physical recovery for the mother and infant. It lasts from the delivery of the placenta through the first 1 to 4 hours after birth. Immediately after birth, the firmly contracted uterus can be palpated through the abdominal wall as a firm, rounded mass approximately 10 to 15 centimeters, 4 to 6 inches, in diameter, at or below the level of the umbilicus. Uterine size varies with the size of the infant and parity of the mother, and is larger when the infant is large or the mother is a multipara. A full bladder or blood clot in the uterus interferes with uterine contraction, increasing blood loss. A soft, boggy uterus and increasing uterine size are associated with postpartum hemorrhage because large blood vessels at the placenta site are not compressed. See Chapter 18. The vaginal drainage after childbirth is called lochia. The 3 stages are lochia rubra, lochia serosa, and lochia alba. See Chapter 17. Lochia rubra, consisting mostly of blood, is present in the 4th stage of labor. Many women are chilled after birth. The cause of this reaction is unknown, but may be due to the sudden decrease in effort, loss of the heat produced by the fetus, decrease in intra-abdominal pressure, and fetal blood cells entering the maternal circulation. The chill lasts for about 20 minutes and subsides spontaneously. A warm blanket, a hot drink, or soup may help shorten the chill and make the woman more comfortable. Discomfort during the 4th stage usually results from birth trauma and after pains. Localized discomfort from birth trauma such as lacerations, an episiotomy, edema, or a hematoma is evident as the effects of local and regional anesthetics diminish. Ice packs on the perineum limit this edema and hematoma formation. After pains are intermittent uterine contractions occurring after birth as the uterus begins to return to the pre-pregnancy state. The discomfort is like menstrual cramps. After pains are more common in multiparas, women who breastfeed, women who have large babies, in cases of uterine overdistension during pregnancy, and in those involving interference with uterine contraction because of a full bladder or blood clot that remains in the uterus. The mother is simultaneously excited and tired after birth. She may be exhausted but too excited to rest. The fourth stage of labor is an ideal time for bonding of the new family because the interest of both the parents and the newborn is high. It is the best time to initiate breastfeeding if maternal and infant problems are absent. The baby is alert and seeks eye contact with the new parents, giving powerful reinforcement for the parents' attachment to their newborn. Duration of labor. The total duration of labor is significantly different for women who have never given birth and those who have previously given birth vaginally. However, women are individuals. Some nulliparas progress through labor quickly, whereas labor for some porous women resembles that of women who have never given birth. Because of the high cesarean birth rate and fewer vaginal births after cesarean, VBAC, a porous woman may have had no vaginal births. In this situation, the woman is likely to have a labor more like that of the nullipara, particularly if she did not labor before her previous cesarean birth. The impact of technology. The goal of maternity care is to protect the health of the mother, fetus, and newborn, and to support and enrich the family's birth experience. Technology helps caregivers identify problems and intervene quickly to promote maternal and fetal well-being. However, extensive use of sophisticated technology may make maternity care seem impersonal. Women may think their feelings are less important than the data from the monitors and infusion pumps attached to them. The nurse should guard against nursing the machines or internal feelings of being unnecessary to the woman's birth experience. If the nurse focuses on the woman as the childbearer and the machines as a tool, frustration for all concerned is less likely. Although normal labor and birth do not require routine use of sophisticated technology, women may quickly agree to suggested interventions and not voice their desire for a low-in-intervention birth. Other women simply have not thought of a low-technology birth, possibly because many friends and relatives have had a high-technology birth. Communication on the indications and risks and benefits to the use of technology is important in planning each individual's care. The intrapartum nurse can be the bridge between the technology and humanity of the birth experience by keeping the focus on the woman, the fetus, and the support person rather than on the technology.